Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 32 of the OBGYN podcast. Today, I am very excited to introduce you to an all-new speaker. Dr. Jillian Kurtz is a chief resident in Columbus, Ohio, and she reached out to me a few months ago about doing an episode. She has a strong passion for reproductive endocrinology and really wanted to spend some time delving into fertility preservation. Now, I don't want to spoil any of it, so I'll let her get started with episode 32, Oncofertility and Fertility Preservation.
First, I would like to thank Dr. Chappelle for creating this great platform for us to discuss exciting and relevant OBGYN topics. Today, I would like to talk to everyone about oncofertility. Oncofertility is a term that combines the fields of reproductive endocrinology and oncology. The main purpose of this field is to expand the options for a reproductive future in cancer survivors. However, this idea can be applied to anyone with a diminished chance at reproduction in the future. Therefore, a more appropriate term might be fertility preservation. From here on out, I will use these terms interchangeably. This is becoming an increasingly relevant topic as survivorship for childhood cancer continues to increase. As treatment improves, children, adolescents, and young adults are now surviving cancer in greater numbers than ever before. According to the National Cancer Institute SEER database, over 100,000 individuals less than 45 years of age are diagnosed with cancer annually in the U.S. And from 2002 to 2012, there was an 83% 5-year survival rate among women less than 45 years diagnosed with cancer, breast cancer being the common in this group. With appropriate pre-treatment planning and intervention, biologic parenthood is still possible for many of these people. Multiple studies have demonstrated that patients prefer to be informed of their fertility options at the time of diagnosis, regardless of the actual risk of impairment, cost, or likelihood of surviving. A survey of survivors, published in the Journal of Sexual Medicine, demonstrated that 1/3 of those surveys would have liked a fertility consultation prior to initiation of treatment. Unfortunately, this is an area that we as providers have historically been lacking. In fact, a different survey showed 73% of survivors saying that they did not receive adequate information and counseling regarding their options prior to treatment. The American Society of Clinical Oncology updated their guidelines to clearly state that a discussion about infertility risks and options for preservation should be included shortly after diagnosis, preferably before treatment begins. A lot of what we know about the effect that treatment of cancer has on long-term fertility is from the Childhood Cancer Survivor Study. This was a cohort study that looked at people who were diagnosed before age 21 and followed them to 30 to 40 years after being treated for childhood cancer in the 1970s. We have made significant improvements in our understanding of cancer as well as our treatment options since 1970. Nonetheless, this study demonstrated that survivors of childhood cancer have a relative risk of infertility of 2.92 compared to their healthy sibling controls. This means that cancer survivors were 3 times more likely to be unable to achieve biologic parenthood when compared to those siblings who presumably had very similar genetics. So now that we've established that cancer survivors have an increased relative risk of infertility, we need to explore why that may be. Cancer is often treated with chemotherapy, radiation therapy, or surgery, all of which have the potential to insult the reproductive organs and result in diminished fertility. Now, of course, there are certain types of chemotherapeutic agents that we know are more likely to have gonadotoxic effects. Alkylating agents are considered one of the more toxic forms of chemotherapy. As you may recall, alkylating agents include cyclophosphamide, carboplatin, and cisplatin, to name a few. These agents prevent cell growth by cross-linking strands of DNA. Because of the continued synthesis of other cellular components, such as RNA and protein, the growth is unbalanced and the cell dies. According to DeSaya's textbook on clinical gynecologic oncology, the insult to the gonads is dose-dependent and also dependent on the ovarian reserve at the time of treatment. The younger the patient at the onset of therapy, the less likely it is the chemotherapy will result in permanent gonadal dysfunction. However, in women older than 30, most regimens are associated with a high incidence of premature ovarian failure. Another commonly used method of therapy involves pelvic radiation. Pelvic radiation may impact fertility both through direct insult to the egg supply and also through interference of the vascular supply to the pelvis, which may affect a woman's ability to carry a healthy pregnancy in the future. In a study by Wallace et al., a mathematical model predicted that 16 gray of radiation would deplete the ovarian oocyte pool at age 20, and only 10 gray of radiation would deplete the pool at age 45 years. Now, it goes without saying that surgically removing pelvic organs diminishes an individual's fertility potential. That being said, a surgeon may take into consideration the risk-benefit of leaving an ovary at the time of surgery to allow a woman to undergo IVF with plans for a gestational carrier in the future. So what are our options? Let's start with males, as this is more straightforward. Men have stem cells within their testes and have the ability to continue making new sperm throughout their lives, well into their 70s. As you know, this is in contrast to females who are born with a finite number of eggs. We will go into more depth about this later in the podcast. With men, our primary fertility preservation option is cryopreservation of sperm. This is a non-invasive and relatively inexpensive way to preserve fertility and should be offered to all post-pubertal and adult males undergoing cancer treatment. While the concept of cryopreservation dates back to 2500 BC, when early civilizations used cold for medicinal purposes, it wasn't until the mid-20th century that human tissue was successfully cryopreserved for future use. The first mention of cryopreservation of sperm was in 1776 by an Italian physiologist named Spallanzani, who noted that sperm cooled by snow became motionless. Initial attempts at cryopreservation of sperm were unsuccessful due to cellular damage that occurred from changing solute concentrations and ice formation. In the 1940s, glycerol was discovered to function as a protectant, and the first human birth from frozen sperm was reported in 1953. Even though this was a huge breakthrough, it was not publicized because the Cook County Supreme Court said it was, quote, contrary to good morals. Of course, there continue to be some barriers to this method. In a large multicentric study from a sperm banking network in France, of over 4,300 young males who visited a fertility clinic, only 93% were able to provide a sample, and only 83% provided enough material to be cryopreserved. There are many reasons why patients fail to provide a sample. For one, the distress caused by a cancer diagnosis, along with the pressure to obtain a quick sample before the start of treatment, may inhibit performance, particularly if their parents are in the waiting room. Second, the patient may be unwell and physically unable to provide a sample. Third, some young people might not have enough knowledge about masturbation, or their cultural beliefs preclude them from performing this act. In this instance, there are other methods for obtaining a sperm sample. Electroejaculation is a method that utilizes a rectal probe to stimulate ejaculation. For those who do not tolerate this, testicular sperm extraction can be performed. This is obviously the most invasive option and is considered a last resort. At this point, testicular harvesting for prepubertal males is considered experimental. Puberty allows maturation of the germinal epithelium to initiate the process toward mature sperm. Therefore, the tissue that is obtained does not have the capability of producing sperm to be used for assisted reproduction. Okay, let's talk about women and girls. As I mentioned earlier, men have stem cells within their testes and have the ability to continue making new sperm throughout their lives. Conversely, women are born with all of the eggs they will ever have. Female infants will have about 7 million eggs in utero, which declines to about 1 million at birth, and by the time she goes into puberty, she has about 300,000 eggs. As noted previously in this podcast, oocytes are uniquely sensitive to radiation injury. One method of fertility preservation is ovarian transposition. Ovarian transposition is a surgical technique to move the ovaries out of the field of radiation prior to treatment. At McGill University in Montreal, the most common cancers treated with lower abdominal radiation are anal and rectal cancers. Historically, ovarian transposition involved medially relocating the ovaries by suturing them to the posterior uterus. One report published in Fertility and Sterility in 2009 reported on 11 girls with Hodgkin's lymphoma who all underwent medial oophorectomy prior to pelvic radiation around age 13. Approximately 15 years later, 14 pregnancies were recorded in these girls, with 12 live births and 3 miscarriages. This study demonstrated that oophorectomies can preserve ovarian function. However, medially displaced ovaries still absorb a certain amount of radiation, So currently, these procedures are done laparoscopically and attempt to transpose the ovaries as far laterally as possible above the pelvic brim. Various locations have been used, including the base of the round ligament, lower level of the inferior kidney pole, and paracolic gutters. A study published in the American Journal of Obstetrics and Gynecology found that laparoscopic ovarian transposition in women less than age 40 is associated with preservation of ovarian function in 88.6% of cases. Now that we have discussed surgical options to get the ovaries out of harm's way in terms of radiation, let's move on to another more controversial topic. I'm referring to hormonal methods used to shut down the ovaries prior to treatment. In theory, it sounds ideal to be able to quiet down the ovaries with Lupron or OCPs prior to treatment. Several studies have demonstrated that ovulation and menstrual function are more likely to occur when chemotherapy was administered concomitantly with GnRH agonist. However, according to the ASRM Committee Opinion on Fertility Preservation, many of these studies had inadequate follow-up. Therefore, conclusions regarding long-term benefit are impossible to make. While GnRH agonists are not FDA approved for this purpose, they may still be used off-label, but we will need further studies to establish the efficacy of this treatment. According to the same committee opinion, the most effective means of fertility preservation for post-pubertal adolescents and women involves ovarian stimulation and subsequent retrieval for embryo or oocyte cryopreservation prior to the initiation of treatment. Prior to the improvements of oocyte harvesting, many women were encouraged to have embryos frozen, as embryos tend to be hardier and were more likely to survive the thaw. The benefit of oocyte cryopreservation over embryos primarily relate to the reproductive autonomy afforded to women with frozen oocytes. Many women undergoing this process do not yet have a committed partner with whom they've decided to form a family. Rather than choosing a sperm donor from a bank, this process allows them the freedom of finding a partner in the future. Historically, success rates of pregnancy resulting from frozen oocytes was quite low. In fact, up until January of 2013, ASRM, the American Society of Reproductive Medicine, considered oocyte cryopreservation as experimental. As you may remember from embryology, oocytes at the time of ovulation are frozen in the metaphase 2, which means the chromosomes are lined up in the middle of the cell with the help of the mitotic spindle. This arrangement, along with the large water content of mature oocytes, makes them particularly vulnerable to the traditional slow freeze process. Modifications in the cryopreservation process have greatly improved success rates. The largest contributor to increased success has been the adoption of the vitrification process. The ASRM Committee Opinion on Mature Oocyte Cryopreservation explains this process. I'm going to save you some of the details, but essentially, vitrification is a method of cryopreservation which uses a large amount of cryoprotectant and utilizes rapid cooling to solidify cells without the formation of ice. Slow freezing refers to exposure of the tissue to cryoprotectant and cooling the tissue slowly to approximately negative 140 degrees Celsius, at which point the tissue is placed into liquid nitrogen at negative 196 degrees Celsius. With vitrification, the concentration of cryoprotectant is much higher, and that rate of cooling is much quicker. The tissue actually reaches the target temperature within minutes. The improved success rates largely contribute to ASRM changing the designation of oocyte cryopreservation to non-experimental status. Another factor to consider is the hormones involved in ovarian stimulation for oocyte retrieval. It can induce a hyperestrogenic state, which may be worrisome in the setting of estrogen-sensitive cancers such as breast, melanoma, or endometrial cancer. A study published in Fertility and Sterility in January of 2018 evaluated long-term outcomes in cancer patients who did and did not pursue fertility preservation. They found that there was approximately a 2-week delay in treatment for women who chose to undergo fertility preservation, which is unlikely to be clinically significant. To expedite the process, most fertility centers initiate a random start protocol rather than waiting until the next menstrual period, as we do for most IVF cycles. The study found that there was no difference in long-term recurrence rate or mortality in those who elected for fertility preservation. They also noted similar IVF cycle outcomes with the classic start versus random start protocols. Now, of course, in women with especially aggressive cancers, Delaying 2 weeks may not be in her best interest, and these decisions need to be made on a case-by-case basis. In contrast to oocyte retrieval, ovarian tissue cryopreservation is still considered experimental. As I mentioned earlier, this is currently the only fertility preservation option available to prepubertal girls. It has the added benefit of allowing these girls to go through puberty after treatment and restore the normal hormonal milieu that would have existed had they not undergone gonadotoxic therapy. It is also an option for individuals with aggressive malignancies when there is insufficient time to go through the usual stimulation and retrieval process. Ovarian tissue cryopreservation is a procedure performed under general anesthesia in which a strip of cortex of the ovary, which contains the follicles, is surgically removed. It is most commonly done through laparoscopic approach. The cortical tissue then undergoes cryopreservation, most often by vitrification. Some women who anticipate having complete ovarian failure after treatment may have whole ovary cryopreservation. Once the woman has survived treatment and gone into remission, she will be a candidate for transplantation of ovarian tissue back into her body. Once the strips are thawed, they can be placed into either the medullary portion of the remaining ovary or to the peritoneum of the ovarian fossa. According to the ASRM committee opinion, the resumption of menses occurs within 4 to 9 months, and 24 births worldwide had been reported as of 2014 with this method. Alternatively, heterotopic transplantation of the ovarian tissue has been performed to the forearm and abdominal and chest walls. Restoration of ovarian function and follicular development will occur, but this method will require the use of IVF for pregnancy to occur. There have yet to be any live births with this method. So what do we do if a woman undergoes treatment which results in ovarian failure and we haven't preemptively harvested oocytes or embryos? If she still has an intact uterus, egg donation in combination with her partner's sperm can always be used for IVF. There are several commercial egg banks available, and success rates with this method are very high. And if all else fails, adoption is another excellent option for parenthood. In general, the highest risk for cancer recurrence is in the first 2 years following treatment, and most specialists recommend waiting this time period before attempting pregnancy. Now, this seems to be somewhat of an arbitrary amount of time. There have been several small retrospective studies that have looked at pregnancies in breast cancer survivors. Some of these studies actually show that women who survive breast cancer and go on to conceive may actually have a better survival rate than their peers who are matched for the same stage and age at diagnosis. In a study published in the American Journal of Obstetrics and Gynecology titled Survival of Breast Cancer Patients After Subsequent Term Pregnancy, Healthy Mother Effect, 91 women less than 40 years old who were diagnosed with carcinoma of the breast and subsequently delivered after treatment were matched with controls for age, stage, and year of diagnosis. The controls had a 4.8-fold risk of death compared to those who delivered after their diagnosis. The authors attribute this to selection bias, as the women who felt better were the ones to go on and form a family, and the women who were more affected by their disease did not. That being said, there are no published data to suggest that postponing conception will alter the outcome of cancer or pregnancy. The 2-year delay primarily serves to deter women who may develop early recurrence. A study published in 2007 out of Australia suggests that waiting only 6 months after diagnosis in women without systemic disease and otherwise good prognosis is unlikely to reduce survival. Now, once a pregnancy has been established, outcomes are generally favorable. A report from the Childhood Cancer Survivor Study, published in AJOG in 2002, did not identify adverse pregnancy outcomes for female survivors treated with most chemotherapy agents. That being said, a woman with a history of pelvic irradiation does have an increased risk of adverse pregnancy outcome with the potential for preterm birth, low birth weight, and small for gestational age infant. These pregnancies may benefit from increased monitoring, including a baseline cervical length and growth ultrasounds in the 3rd trimester. Now I'm going to shift gears for a few minutes and discuss transgender issues. According to an analysis done by the Williams Institute, as of 2016, about 1.4 million adults in the U.S. identify as transgender. Young people aged 18 to 24 were more likely to say they were transgender. A survey of transsexual men published in Human Reproduction in 2012 found 64% of those surveyed currently in a relationship, and about half of participants desired to have children. That makes about 450,000 people in the U.S. who identify as transgender and wish to form a family. Therefore, the World Professional Association for Transgender Health recommends discussing fertility and fertility preservation options with patients before initiating any treatment. It is important to note that many of the concepts we have discussed are applicable to fertility preservation in the transgender population as well. As a component of the transition from male to female or female to male, exogenous hormones or surgery may preclude a person from being able to start a family. Prior to initiating this transition, a discussion regarding the reproductive plans is imperative. The effects of prolonged treatment with exogenous testosterone on ovarian function is unclear. Testosterone therapy usually leads to an anovulatory state in amenorrhea. Oftentimes, this is reversible upon discontinuation of the therapy. Anti-Mullerian hormone, which is produced by the granulosa cells of the antral follicles, is often used as a measure of ovarian reserve and can be used to predict responsiveness of the ovaries to gonadotropins during stimulation. A study published in Fertility and Sterility in 2014 demonstrated that AMH levels decline in female-to-male transsexuals who use exogenous testosterone. How quickly the ovaries might rebound after cessation of testosterone yet to be studied fully, but in any case, we can conclude that there is some insult to ovarian function, at least temporarily, with testosterone use. Light et al. Examined this in their cross-sectional online survey of 41 transgender men. Of those surveyed, 61% reported testosterone use prior to pregnancy. 80% of the testosterone users resumed menses at 6 months, and 72% had conceived by 6 months. Obstetrical outcomes are shown to be similar in testosterone users and non-users. Not surprisingly, the use of exogenous estrogen in the male-to-female transgender population has a similar effect on gonadal function. A paper published in 1992 reported the findings during treatment of a 36-year-old with gender dysphoria transitioning from male to female in Berlin. Now, it's worth noting that while it was previously common practice to prescribe oral ethinyl estradiol for male to female transitions, per the World Professional Association for Transgender Health, it is now thought to be too high risk for thromboembolic and cardiovascular disease. Most endocrinologists opt for oral 17-beta estradiol or transdermal preparations. In any case, at a dose of 20 micrograms ethinyl estradiol daily, there was no negative effect on sperm motility and density. At higher doses of 60 micrograms per day, decreased sperm motility was seen after only a few days, and decreased sperm density was seen after 2 weeks of therapy. This is thought to be due to the negative feedback mechanism on pituitary secretion of FSH. So ultimately, in either case of male to female transition or female to male, the involved hormones seem to have a negative effect on gonadal function. How reversible this effect may be is still unclear and is being evaluated. Ideally, transgender patients should be encouraged to consider banking their sperm or undergo oocyte cryopreservation prior to initiating treatment. Some providers have expressed concern for the suitability of a transgender person to become a parent. While the literature on the topic is limited, the most recent data comes from a study of French children conceived by donor insemination, born into families with a transgender man and his wife. Evaluation by 3 different mental health professionals concluded that the children were healthy, well-adjusted, and exhibit secure attachments to their parents and did not display any gender-variant behaviors. Both ASRM and ACOG support fertility preservation options to individuals prior to transition. Now, this pretty much wraps up my discussion on fertility preservation. Big thanks to Dr. Chappell for having me on the show.
Thank you so much to Dr. Kurtz for putting together that wonderful talk on fertility preservation. I hope you all enjoyed that and learned as much as I did, and I know that I look forward to having Jillian back on for as many episodes as I can get her. As a reminder to anyone else, if you are interested in taking on an episode like Dr. Kurtz did, then please just get in contact with me at feedback@obgyn.fm. You can also send any questions or comments to that email as well. And the last thing is, if you are interested in the Slack group, please do give me an email, same place, and I can get you an invite. Now, I must confess, it's been a little quiet of late, but there are a number of great people on there, and I still want to try to make it a community for all of us. This includes medical students, so please, if you're a medical student and you listen and you're interested, shoot me an email and I'll get you an invite. But anyway, thank you again so much, Dr. Kurtz, for that wonderful episode, and thank you all for listening.